So as I said, tonight's presentation is why hysteropexy, a female urologist, offers minimally invasive approach for pelvic organ prolapse, hosted by Lena Medical and FemSelect. This will be presented by Dr. Grace Biggs. Next slide, please. FemSelect follows AdvaMed guidelines and Sunshine Act reporting rules. Dr. Biggs, proctor for M-Place, speaker for FemSelect, speaker for Axonics, no other disclosures to be made. Next slide. She has practiced all aspects of urology with a particular focus on female urology, including pelvic organ prolapse, incontinence issues, overactive bladder, non-invasive surgery, robotic surgery, and reconstructive pelvic surgery. I'll now turn it over to Dr. Biggs.
Thanks, Adam, for the introduction. Thank you, everyone, for being here tonight. I know it's difficult after a long day at work, so I'll try to just keep this very high yield and get through the slides about 30 minutes and leave a lot of time for questions. So before I dive into it, just wanted to give a little bit further introduction as to my own experience. After fellowship, I joined a large multi-specialty group, about 300 physicians in a suburb of New York City, and practiced there for about 7-8 years, and practiced all aspects of FPMRS, doing robotic hysterectomy, sacrocolpopexy, all the vaginal prolapse repairs, and mainly using mesh because that's what was popular at the time. And I loved doing mesh surgery for prolapse repair and had very good results, fortunately. And left that practice and joined a hospital-based group, and that's where I am still and have been here for about 7 or 8 years. And unfortunately, when I moved here, the one downside was that there was no robot available at the time, but they were planning on procuring one. And in the meantime, I was fine with it. I would offer abdominal sacrocolpopexy, but also vaginal prolapse repair with mesh. And so, everything was great and going well. And then, as we all know, the mesh debacle occurred, and suddenly I didn't have the use of mesh. And many of us are returning to or doing a lot of robotic sacrocolpopexy and doing traditional biologic mesh repairs vaginally. And so I didn't have the robot available, so I was doing abdominal sacrocolpopexy and this biologic traditional repair. And I was really not happy. Obviously, we did eventually get a robot, and now we have 2 robots. But in that interim, I was struggling to figure out how to do, vaginal repairs that were good enough for the patients and me as a surgeon, with great results, happy patients with minimal recurrence. And I was trying to think of procedures myself to somehow come up with something that I could bring to a company, just trying to think of all kinds of options. And during this time, a couple of years ago at SUFU, I ran into Dr. Vincent Lucente, and he happened to be having a conversation about this procedure. And I was walking by, and he pulled me in, and I got involved in the conversation. And I was really fascinated by what he was telling me and his experience. And so after leaving that conference, I went and I did a little bit of research on hysteropexy and so forth. And I found out some very interesting information. So here on this slide, I didn't realize that it's the second most common procedure in US women, totaling 600,000 per year. So 20 million women have had a hysterectomy up to this point. A third are done by age 60, and more occur in community hospitals versus academic ones. And it varies in terms of rates by geographic location, rural versus urban residents, race, age, and ethnicity. Next slide, please. And so even more fascinating was the fact that 90% of hysterectomies are performed for benign procedures. So only 10% are done for cancer. I found that astounding. So theoretically, 90% are not necessary. And, we do super cervical hysterectomies for the abdominal colpopexies. But why are so many hysterectomies performed for benign disease? And I think there's several reasons for that. There's this pervasive, prevalent myth that's not only in medicine, but obviously in the lay population, that somehow the uterus is disposable after, the whole primary function as of the uterus being a childbearing organ. Who needs the uterus? I think there's some kind of subversive thought like that is really pervasive in our culture. And also, decades ago, it was thought that women's hysteria was held in their uterus, and why is called a hysterectomy. And so all these are quite archaic and even, kind of shocking to hear, but I think many of us have encountered that. And interestingly enough, the ACGME requirements for GYN residencies are 85 hysterectomies, and that's up from 70. And yet there's no requirements for myomectomy. So just even requirements in our residencies are more hysterectomies than minimally invasive surgeries, and that's probably going to change in the future. But also, I think that once we learn a particular surgery or procedure in residency or fellowship, we're more apt to do that once we get out into practice. But we're not technicians, we're surgeons, and I think we really need to learn new procedures, think of new ways to approach things, especially in the environment of mesh being taken away and different things happening in medicine where we have to rethink, reevaluate, and research as to why we do the things we do and whether it's still appropriate. And so the trend has been slowly that actually hysterectomy rates are decreasing and minimally invasive treatments are increasing. And I think a lot of this is because IUDs are being used more for uterine bleeding. You have uterine lining ablative treatments that are office-based or ambulatory surgery-based, and myomectomies are increasing. And so there's a lot of minimally invasive procedures that are available to gynecologists for things like uterine bleeding, which are a great bulk of the reasons why a lot of women get hysterectomies. There's also the reimbursement and economic factor. I think we're seeing that more as we see that medical care costs are just skyrocketing in the US. And there's a lot of changes that are taking places in academic centers and hospital centers, and mainly because reimbursement has changed. And there's even been evidence where surgeons are asked to look at their surgeries because the surgery time on the robot are too long and it's costing too much money to use the robot for certain surgeries. And so these are things that we all have to be cognizant of. And especially now with aging medicine and women's health medicine coming to the forefront, more knowledge being learned about menopause, genitourinary syndrome of menopause, we're learning more about women's health. And taking out the uterus, I think there are more consequences to that than just taking out an organ. At least in urology, we certainly don't take out men's testicles or so forth when they're done having children. And so that seems a little drastic, but that's kind of what we're looking at, I think. And so in that context, I'd like to talk a little bit about why I do Nplace. And so we have here a paper about hysteropexy compared to hysterectomy for prolapse repair, which is safer. And in this particular study, they found that hysterectomies were longer, had higher blood loss, and a longer hospital stay. And so the blood loss was about 3 times as much for the hysterectomies versus the hysteropexies. And there were 4-fold higher odds of experiencing some type of perioperative adverse event with the hysterectomy. In a separate paper that is a systematic review looking at uterine preservation versus hysterectomy and pelvic organ prolapse surgery, next, there were again lower adverse events, things like UTIs, retention, ureteral injury, surgical site infection, neurologic injury, and specifically operative times were much longer with the hysterectomy arm. In a separate paper looking at comparative aspects of sacrospinous hysteropexy versus vaginal hysterectomy with uterosacral ligament suspension in stages 2 or higher, and this was a randomized trial in a multi-center, and they found that there was significantly less anatomical recurrences in the hysteropexy arm. And there was statistically significant less failure in the hysteropexy group at 5 years at 1% and 8% in the hysterectomy group. In terms of the composite outcome of success between the two, it was 87% success in the hysteropexy group and 76 in the hysterectomy group. So these are statistically significant. And then when we think about what the gold standard is, which is the abdominal sacrocolpopexy, and since the mesh issues and taking away the kits and so forth, it turned to robotic sacrocolpopexy because robotic surgery has increased and the beneficial aspects of it over open are known to everybody here. And so my question is really, should there be a paradigm shift back to vaginal surgery, especially with a device like M-Place available? Because when we look at some of the complications that can occur with robotic surgery, I think we really need to ask ourselves, why are we approaching a pelvic organ prolapse problem, a vaginal problem, via the abdominal route? Is it really the route of choice for surgeons and for patients? And some of the drawbacks are there can be device and instrument malfunctions, there can be broken pieces left behind, that's up to 15%. There could be technical and troubleshooting issues like instrument arcing, assistance using instruments in unintended ways, system errors, imaging problems, all kinds of technical problems that you would never encounter with vaginal surgery. And then device malfunctions or needing to convert to open or having to reschedule it, which is ranging from 2, 3 to 10%. But when it happens to a patient, it's 100% very frustrating and really to some degree devastating when they have to look forward to another surgery. And so are the complications of robotic surgery really overshadowing some of those minor mesh exposure complications we are encountering as pelvic surgeons, which were mostly mesh exposure, mesh extrusion, and those other complications? Yes, they exist. I think we all know that. But were those the predominant complications for most of us pelvic surgeons? I don't think so. And so do we owe ourselves to return to vaginal surgery as the more predominant type of surgery that we offer? Now, I still offer all the different ones, and surprisingly, I have found that the patients often choose vaginal surgery if that's the option, and it is with good results. So let's dive into a little bit more about that. But before we do, I did want to give one example of, just in terms of urology, even in prostate cancer surgery, robotic surgery was so pivotal and a game changer for that type of surgery compared to open, because the blood loss was 1 to 2 liters and it went down to 100 cc's. And the visualization of the nerves and the vessels really reduced erectile dysfunction, incontinence, and so forth. But even in prostate cancer surgery, much of surgery in general is moving towards minimally invasive, and that's focal therapy for prostate cancer, watchful waiting. And so I think we constantly need to think as surgeon, what is the most minimally invasive route and the safest, most cost effective, and most satisfactory for surgeons and patients. Next slide, please. So why do I choose M-Place and why do I continue to use it after having started about 10 months now? And with the aging population increasing, with the incidence of pelvic organ prolapse incidence increasing with that aging population, younger women want other options. And these younger women are the daughters of the older women who we see who have prolapse. And so the older women are also asking these questions like, why do I need to have my uterus removed? And then with the mesh kits taken off the market, I think M-Place uses a novel idea by using an anatomical organ to bolster the prolapse repair. And so let's dive into what M-Place is. It is a product that has been FDA approved, and it is a device that helps, or it's indicated for attaching sutures to ligaments of the pelvic floor, and it's intended to be only used by physicians with appropriate experience in the pelvic floor repair. And this is a single-use product. It should never be re-sterilized and should be carefully looked at prior to using it to ensure that it's functioning properly. And the device should only be used by physicians in patients that are appropriate for this particular surgery. The one contraindication is that it can cause an issue if a patient is allergic to nickel. And otherwise, just like any other sacrospinous ligament fixation device, it can cause injury to nerves, vessels, bowel, urinary tract, pain, fistula formation, and temporary reaction to the foreign body. So the one disclaimer, M-Place is not a procedure. This content is provided for educational and informational purposes only and should not be considered medical advice and is not intended to replace the independent professional medical judgment of a licensed physician with respect to particular patients, procedures, or practices. So what is M-Place? It's actually two elements. One is the anchor suture unit, and the other is the finger-guided delivery system. And it's a patented finger guide, and it's a working channel that helps you to insert and deploy the anchor unit very precisely and percutaneously. That's really the part that's so important here, that is percutaneous placement, obviating the need for the traditional dissection that we typically do in the anterior vaginal wall, and it precisely embeds it into the sacrospinous ligament. And so bilaterally, we're attaching this nitinol anchor to the sacrospinous ligament for either a hysteropexy or a colpopexy. So this is just a close-up of the device. That's the anchor, which is 2 millimeter in width, and when it's deployed, it's 4 millimeter with the two wings. You got the finger guide for the right and left fingers, and then the safety release trigger that you push down. And so it's a direct puncture right through the vaginal wall. It's very accurate, and because of that, it has a very strong safety profile. Minimal infection, minimal blood loss, minimal tissue scarring, and minimal injury. And so this decreases operative pain and standard compared to standard traditional dissection. And so it decreases operative time, which is huge. It's basically a 30-minute procedure. And it decreases costs by decreasing OR time, length of stay in a hospital, and anesthesia time. And really, it allows preservation of the uterus and cervix. And I think a lot of women appreciate that now. And so there's also a faster return to normal activity, which we all want for our patients. And we certainly, as surgeons, want to spend less time in the OR. The learning curve is about 5 cases, and it's going to, vary by surgeon. And the proficiency, really, I found very helpful was the model that the M-Place rep brought to my office, and we'll see a picture of that later. But it really allowed me to picture the 3D pelvic anatomy and how the M-Place device is angled and how it's used to place the nitinol anchoring unit, and then how to bring the sutures through the cervix, how to tie it. And so you get to practice all that before you actually do it in a patient. And it's not a cadaver, so you don't have the smell, but the model is actually quite good. And this particular slide describes Vincent Lucente's experience over 5 years, and he's done approximately 450 cases, which is probably up to 500 by now, with less than 1% complications, all minor and resolved. He had a total of 8 failures that required reoperation. And what I found interesting is all those patients opted for repeat M-Place. So you know that it's a very tolerable procedure if a patient's opting to have it done again, and there's trust in the surgeon. He found it to be a very transformational experience for the patients and for himself, and I'm finding that to be true also. He's found increased referrals for prolapse surgery, and I've also found that to be true. And he also even goes to say that he feels that it's a paradigm shift that surpasses what the midurethral sling was for stress incontinence. And I'm finding that to be true also. His direct quote is, "I've done over 450 procedures, all taking about 30 minutes. I found the M-Place procedure relatively easy to perform, and my patients recovered very quickly. All my patients have resumed an active lifestyle, including intimacy. It's become my procedure of choice for patients that have been using a pessary because they didn't want the more extensive traditional surgery. So these are a few studies put out by the company, and one is a 4-year study. It's a small number of women, 15 women, who were diagnosed with symptomatic recurrent stage 3, and the age range was from 40 to 85. The median follow-up was 51 months, and there was 92% success rate. That's pretty much equal to the sacrocolpopexy. And yes, it's a small number, so obviously more studies need to be done. There was a 12-month post-market clinical study, and it had 56 women with symptomatic stage 2 or more, and it was 123 consecutive patients, and the end outcomes was a POPC score of greater than -1 centimeter. Satisfaction was improved significantly. Complaints of bulging decreased significantly, and 76% of women reported no post-op pain and received no pain medicine after the procedure. The average duration was 26 minutes, and they had a tablespoon of blood loss, and there were no unanticipated adverse events. I think that's quite remarkable. This is a study by Dr. Gold. This was a study with 123 consecutive patients. There were no complications related to the device, low blood loss again, fast operating times, discharged on the same day, safety, minimal blood loss, low operative time, and very efficacious. And there were 2 arms, hysteropexy and vaginal colpopexy, and the recurrence rate was very low at less than 9% and 6%. So how does the M-Place differ from the traditional repairs? So there's less surgical dissection, which means less blood loss, less surgical time, uterine preservation, faster return to daily activities, no hospital stay, and of course we're avoiding mesh-related adverse events, and we're having less complications like nerve entrapment, excessive blood loss, postoperative pain. And you can do this under light sedation, which is what Dr. Lucente does. I do use LMA, and they do really well, but theoretically you could do it with light sedation, and it reduces cost, as we've said over and over, and it really enhances the patient's overall experience. And I think that's what we really want for our patients: durability, safety, and for a patient to have a great experience with their surgery. And the standard repair we know is the biologic graft, or it's increased dissection, increased surgical time, and so on and so forth. So this is a picture of the incision you would make 2 centimeters above the cervix, and this is done after the 2 M-Place sutures are placed through the sacrospinous ligament. It's the shape of an upside down smiley face, or the hood of a car is how it's described. This is a picture where Dr. Lucente has marked out the hash marks are where he will dissect the anterior vaginal wall from the cervix and remove that excess tissue. And so you see the picture of him tenting that up, cutting into the cervical fascia and dissecting that free. Very minimal blood loss. You do some local in that anterior vaginal wall first. And here you see the sutures coming out, where we place it using either a Mayo needle or Ferguson needle, and you take the individual sutures, so you're making 4 passes, 2 on the right, 2 on the left, puncturing back through the area where the sacrospinous ligament was originally punctured with the device, and bringing it back through the cervix on the right and left side. So this is a cartoon picture of it. So this is where the sutures come through in two separate areas on the right and left side. If you could go ahead and click on those. Once that's done, what's really, really important in this surgery is to tension it and tie the knot correctly. You do not want there to be air knots. The 2 Alice clamps are pushed and pressure applied while you're tying it down by an assistant, and making sure that each knot is going down very clearly and with no air. And so you do about 8 throws each side. And then once you do that, you go back one slide. Then we do something called the seatbelt suture, where you bring those two sutures on the right and left and tie them together. That's the previous slide. And that's considered the seatbelt. And so that gives a further reinforcement of the repair. Now, go to the next slide, please. If you look at the second to last square there, you do want to pre-place 2 ovicral sutures on the edge of the incision. That will make it easy, and you do a few throws, and so that will make it easier to close that incision once it's deep into the vaginal canal. And then you're done. Well, I always do a cystoscopy with methylene blue to check the ureteral orifice that they have not been obstructed. So in terms of patient selection, age, I think I haven't offered it to any patient that's still a childbearing age and who still intend to have children, but I've done it in patients who are in their 90s, specifically patients who've been using pessaries and really hate the pessaries, and this was a great option for them. In terms of anatomy, this procedure is going to be easier if they have more uterine prolapse, grade 1 prolapse of the uterus. You may want to use a Carter Thomason to go through the cervix and down through to the site of insertion of the suture, because it will be a lot easier. When you have grade 3, 4, or prosodentia, and I've done this procedure in patients with prosodentia and they do great, it's much easier to use the Mayo or Ferguson needle. In terms of previous surgical history, I really think it's suitable for most surgery. I've done it in a patient who failed mesh and she did great. So haven't had any issues there. Sexual function, if they're sexually active, this is a great surgery for it. In terms of minimally invasive or less invasive approach, obviously if the patient desires that, this is a great option. Faster return to physical activity and the anesthesia concerns we talked about earlier. So in comparison to the robotic sacrocolpopexy, there are certain strict requirements because they're put in severe Trendelenburg. So there are certain instances where a robot may not be the most optimal choice. You have to use mesh, and the patient would want to have this more invasive procedure requiring a longer postoperative recovery time. So there's a lot of reasons why this might be something you want to consider. So in conclusion, I really hope that this might have sparked some interest in doing this procedure. I really encourage you to just book a few cases or meet with the rep and look at the model and see each step of the surgery. It's a great surgery. I've really enjoyed it. Again, like I said, I've been doing it for about 10 months. I've gotten many more referrals. I can do 5 or 7 cases in a day. Whereas when you're doing a robot, you're probably doing 3 at the most. So think about it and let's bring the vagina back into the picture.
Thank you so much, Dr. Biggs. That was a fantastic presentation. You covered a lot of ground, and your personal experience really, I think, is most important here and really fascinating. I think it's the fact that you've taken so many patients from this this thought of I have to have my uterus taken out in order to have the prolapse repaired, and this big surgery and robotic sacrocolpopexy and all that kind of stuff, and boiled it down to something that's really quick and easy. I'm waiting for some questions to come in through the chat, but some questions we always get from physicians are what's your common what are your most common procedures to be done with the end plates? I know Dr. Lucente has his blue plate special, he calls it. Do you have a pretty recurring set of procedures, or does it differ?
It differs, but I often have triple compartment prolapse, so I often do a rectocele repair with it. often have simultaneous stress incontinence. So I'll do either a sling or a bulking procedure. So yeah, it can just vary. It might just be the end place uterine prolapse and cystocele 30 minutes I'm out, or it could be some combination of the ones I just mentioned. And even with the full kind of blue plate special, it's a little over an hour. So it's pretty quick.
Okay, and you address some of the clinical results. Are you seeing similar results in your patient population? And when do you usually see results? How soon after the procedure? And what do you usually find?
So I see patients back 2 weeks and 6 weeks, and then yearly. And up to now, great results. Patients are extremely happy. They're so happy. One, they're surprised by the postoperative experience because they talk to a lot of friends, friends, family members, and they know about the 6 week recovery time and so forth. And so they're really pleased with the recovery. Now, having said that, if I do a rectal at the same time, that's one of the more painful surgeries. So they understand that, but they really are very pleased with the lack of postoperative pain and just feeling great so quickly.
And so, what are your standard marching orders for them post op?
For all prolapse patients, I really ask them just lifelong going forward to restrict things like squats with weights or running as a exercise. I would choose elliptical exercises or yoga, Pilates, things like that, as opposed to like pounding exercises. People who are chronic coughers or chronic constipation, I really try to improve that because that repetitive nature of activity is going to be bad for prolapse in general, no matter the repair.
Of course. And in converting patients, or not, maybe I shouldn't say converting, is offering this option as opposed to your robotic sacrocolpopexies. Is there particular guidelines that you have in mind when you see a patient? Oh, this is probably a better end place patient than a sacrocolpopexy. Is it always just women who want to retain their uterus? How do you kind of divide that? See that in your patients?
So once when I was sharing with one of my gynecology colleagues saying how everyone seems to choose vaginal surgery, he said it's probably the way you present it. So after I had that conversation with him, I literally, with all the prolapse patients, present every option. I say you could have robot with mesh. You could have vaginal surgery with or without mesh, because very selectively, especially in recurrence, still offer it, but obviously counsel very heavily that I use free form, polyform, and the dangers of mesh and so forth, but I still offer it. And so I let them make the choice. If they ask me what I think should be done, if they have a uterus and cervix and there is at least grade 1 prolapse, I say M-place is a great option. And also with all the pessary patients, I always revisit that and always did before this procedure. But now it's even more enticing to say, hey, there's this great new procedure that is really minimal invasive because many of them are older. They don't want to be under anesthesia or they can't be under anesthesia because of, comorbidities and so forth. And so this is a great option. And again, I had 2 patients like that today.
Awesome. Are you do you get any pushback from patients about the anchors, or do you have any personal concerns about the permanent anchor? Other than the nitinol nickel allergy, obviously that's a non-starter. But do patients have do you ever show them the actual little anchor and it's tiny, or do you get any pushback or concerns from patients about the anchors?
I haven't up to this point. And honestly, compared to thin capio, um, some of the other devices that are out there that go around the ligament, I prefer the puncture method better. I think there's less likely ureteral injury. Haven't had that up to now, but I haven't had any issue or any questions about that yet.
Great. So a couple of in the procedure itself. Are you and we sometimes get some surprise from physicians when they actually check for the anchor placement. Do you check, and when do you check, and what is it you actually feel? Because as you know, we get this question from a lot of physicians, and as a sales rep, I can't really tell them what it feels like. So where do you feel the anchor? How does it feel? What do you find when you check your
I
placement?
always check the placement and the strength of it. So once I've deployed it and I think it's good, I actually I put a clamp at the end and I will tug on it quite rigorously to see where it is in terms of the location of the ligament and then how strong it's in the ligament. And there have been a few times I have removed it and redeployed it. And you can do that. You just squeeze with the clamp and you place it back into the device and it's worked fine.
Great. Um, the other question in here was about oh, getting the product into the hospital, and do you get pushback on either, reducing your robotic cases, or as far as, getting the product into the hospital, explaining to them what you're doing? Does the hospital understand, or did it take you a lot of convincing to tell them, hey, this is what I'm trying to do? These are patients who want to preserve their uterus. It's an easier procedure, less invasive, and all that. What, how did that go with the hospital?
I've had zero issues with the hospital. They've never asked me about it. They're just happy I do so many cases, frankly. And actually, MPlace has its own CPT code now, CC9778.
Yep.
So that's great. That's a recent development. And I think that this is just going to become a more used tool by more pelvic surgeons. So no pushback from the hospital. If anything, I think they're very happy because I'm doing more cases.
Yeah, yeah, that totally makes sense. I think that might do it. Oh, as far as your personal cases, average blood loss, or have you had any? And I hate to jinx you by asking you a question about complications, but have you had any particular complications in your own cases?
Sure, no problem. I don't believe in jinxing, so that's okay. Um, I have not had any ureteral injuries. Blood loss is similar to what everyone else has said. Um, not even 100 cc's. Uh, so most like 50 cc's. And pain has not been an issue. And yeah, really nothing. I've not had any infections and no recurrence as of yet.
That's great. That's great. Um, well, I think we're still a few minutes short, but I don't see any other questions coming through.
But one thing I wanted to
So
mention was even because, I did vaginal hysterectomies and I haven't done any since I started doing this because even in Procedentia, I have done this procedure. I've done a handful now, have done great. So even with complete uterine prolapse that I would typically have done a vaginal hysterectomy, I have not had to do that.
just curious, how far into the number of cases you've done did you see full prostodentia and take it on? Because I know Dr. Lucente also said that, but he's got such a large volume of cases. It's been a long time. Was that your third, fourth, or maybe a little further down the road?
Further down the road, but actually that's one of the simplest ones to do because it's just hanging out. Because usually with grade 1 or 2, we have to pull on the Alice's, and this one's already hanging out of the vagina, so the suture placement through the cervix is so much easier, really. But I just want to encourage anyone who might be interested, don't get frustrated those first 5 cases, especially if you have like a grade 1 uterine prolapse. Those are the toughest cases. And the Carter Thomason is extremely useful in that situation. But having a good headlamp or really good light and having great assistance is really, and I don't have residents, I just have the surgical tech. As long as you tell them what to do, I think that is the hardest part of the surgery. And once that's overcome, it's smooth sailing.
That's great. One last question. Sorry, this one just came in. As far as I think another one of the other physicians had asked about using stool softener for the patients 2 to 3 weeks. You have any specific post-op protocols other than what you mentioned as far as physical exertion and that kind of thing?
Yeah, so I'm a huge I talk about constipation all the time. And so, yes, I want all of that to be started prior to the surgery. I'm a huge probiotic user, and whatever works for the patient. If they already have a regimen and that works well for them, I have them do that and then start immediately after. I don't restrict any kind of food, but I always encourage a Mediterranean diet. And so, yeah, I encourage stool softeners, probiotics. I try not to say laxatives if possible, but just more the natural way. If but clearly these days the constipation is a huge problem. So there are people who are on, prescription medicines like Linzess and so forth. But I really try to encourage my patients to use probiotics and do more natural methods.
Okay, great. I think that's all the questions that we have. Again, I want to thank you for your personal experience, for your use of the N-Place device and sharing that with all of us. This has been fantastic, and you did a great job covering all the information, clinical data, and everything that was here. So, with that, I think we will now end the presentation, end the webinar. And again, thank you so much. Oh, any of the participants, just make sure that you do, as Dr. Biggs suggested, reach out to your local Lena rep or FemSelect rep to talk about training. We offer multiple ways of getting training. Again, this presentation is not intended to train any physicians on the procedure itself. There's not enough time to do that, and we want to get hands-on types of training. So make sure you contact Lena Medical or FemSelect for any further questions or training, and we will put this webinar out for everybody to review whenever they'd like. Again, thank you so much, Dr. Biggs. Fantastic job, and we'll see you soon.